Hello, PsychU community, and welcome to today's webinar, The Power and Impact of a Recovery-Oriented Approach in Behavioral Healthcare Delivery, Part 1. My name is Dr. Nicole Mead, and I'm from the Otsuka Medical Affairs team. I'll serve as the moderator today for this exciting discussion featuring 3 experts in the field, Harvey Rosenthal, Dwayne Mayes, and Alison Carroll. This virtual forum is sponsored by Otsuka Pharmaceutical Development and Commercialization, Inc. and Lundbeck LLC. So welcome, speakers. We're going to go right into our first slide here. Alison, would you take us through the left-hand side of this slide this afternoon?
Sure. Well, we're going to be talking about a recovery vision, which is strength-based. First, we want to look at adjustment to disability. And I'd like to actually point out that word is actually not even in favor anymore so much with the field. It's focusing on a negative. This is about a strengths-based perspective. So we are trying to look at people and what strengths they have. Disability, just the prefix dis, is apart, asunder, having a negative force. So not that we don't understand that people have symptoms and things going on in their life, but we really want to focus on the strengths and the positives. So instead of looking at a disability, which is a label, it kind of leaves us dry, saying, okay, they're disabled, we're not going to focus on that person. So we want to look at the strengths. So, but still adjusting to that disability, that whatever is causing you difficulty. And we would like to see a system that people with mental health conditions get the help they need and they don't have to pay that price of their dignity. And what that is talking about is really when people are diagnosed with mental health conditions, we often strip them of credibility, of their dignity. They don't have a say in their treatment. So we want people to be able to adjust to what's going on without losing that. Simply as if someone with diabetes adjusts to life looking at their blood sugar and they're not just labeled as, diabetic, now we know all about them and then they're cast aside. We want to look at empowerment, giving people back strength and a right to have a say in what goes on in their life. And again, not defining people by labels, but by people. And then self-determination and believing that people with mental health conditions do have aspirations and goals, the same as anyone else would.
So Dwayne, why don't you take us through the next slide and go through the basic principles here?
So these are the basic principles of a recovery plan. We have to start with the concept and belief that recovery is possible as defined by individuals. It can occur without professional intervention, and it occurs in the presence of someone who believes in it, stands by the person. It involves more than just symptom reduction. It's highly individualized, and recovery from the consequences of the illness is sometimes more difficult than recovering from the actual illness itself. One of the stories that I've always held on to is when I was in a day treatment program, and a buddy of mine and we would walk from this program, a 20 to 30-minute walk, and we would share with each other how we were feeling. And we would share just from one guy to the other what's really going on with us, things that we did not feel comfortable discussing in the treatment setting. And we got more benefit from just having that walk and talk with each other, supporting each other in a non-judgmental way than we ever got from the traditional support. And I've always held on to that. That is the power of peer support through a recovery lens, where we were able to help each other go through and work through the things that we needed to.
So I have the privilege of having worked with some of the movement's founders, because I'm so old, Nicole. But really, back in the day, our movement really was preceded by the civil rights movement and the LGBTQI movement and the women's movement. And they had Seneca Falls and Stonewall and Selma. We didn't. And then came the ex-patient survivor movement. Judy Chamberlain was a part of that movement. Judy Chamberlain had a miscarriage and the distress associated with that. She was hospitalized and told she would never recover. She fought against that and really founded. She's the godmother of the movement and wrote a book called Patient Controlled System and what have you. We've had a whole series of people that really were heroes. One of them is Ed Knight, who was my mentor. Ed Knight tells the story. He was homeless. He was hospitalized. He's in a unit. He wanted to be a researcher, he told them. So he's ready for discharge, and they said, what's going to happen? He said, well, I want to be a researcher. Uh-oh, he's symptomatic. We better keep him here. So a few weeks later, they ask him again. He says, I want to be a researcher. They don't discharge him. They ask him again. He says, I want to be a janitor. They discharge him. He becomes a researcher, a famous researcher and a famous advocate for peer support and recovery, and a dear man. I love him so. So we have a whole series, as Alison pointed out, of movements that have occurred. Right now, the peer support movement is really at the edge of what we're doing. But it's been one on top of the other. Independent living centers, one after the other, built on themselves, and really gave us this strength and this desire and determination to do all the things that we're talking about today. There would be no recovery rehab movement had it not been all those movements that came before and all the people that created ours.